I welcome you all to the second webinar organized by PSH. So this time we selected the topic of hematological aspects of COVID-19, and we have invited panelists from all over the globe. Thank you very much all the panelists for joining us and sparing your precious time. First of all, I'll invite Dr. Ghulam Nabi Kakepoto. He's the consultant hematologist working in UK. Sir would throw light upon pathogenesis and symptoms of COVID-19. He has been always a very active member of PSH, may it be a HemeCon or may it be a webinar. So thank you very much for sparing your precious time. Over to Dr. Ghulam Nabi Kakepoto.
Thank you very much, Marine. I really thank to the Pakistan Society of Haematology for inviting me to present my thoughts about this COVID virus in this webinar. What I'm going to do is set the scene. There will be very minimal hematology, but generalized aspects which will interest you. So what I would suggest to the audience to get a cup of tea and a coffee and enjoy the ride. There's no conflict of stress, and as I said, I'm thankful to the society for giving me this task to talk about the COVID virus. This is the headings which I'm going to dwell a little bit, and then I'll hand over mic to Dr. Hashmi, who will dwell in a greater detail about the hematology of the COVID-19. This is the virus which is talked a lot in the recent last 6 months or so, and every single person on the face of the earth knows about this virus, whether he or she be a clinician, scientist, politician, layperson, hakim, you know it. Anybody, everybody is expressing her thoughts about the virus. It's a new virus, it's a novel virus, and it causes a flu-like illness, and it's called SARS-CoV. I'll come to the detailed nomenclature later. So the question was, if it's just a simple flu virus, as the President Trump puts it, is it really, should we worry about it? He's right that it is a flu virus, and most people recover with minimal or no symptoms without any problems. However, we need to understand one thing, that it is very unpredictable. Many fit and young people have had severe illness, and some of my very dearest friends have succumbed to it. And one of the good friend was Dr. Tariq Shafi, who was our colleague hematologist, unfortunately passed away. He was only 60 years. One of my class fellows, Dr. Fasihuddin, he was a chest physician. He just passed away a few days ago. So there are a number of people who are fit, healthy, they contract the virus and they pass away. We are learning every single day about this virus, something new. And the question was, the big question was, can we predict who gets a severe disease? Yes, to some extent, maybe in people who are of older age, 60 and above, like what happened in the UK, as you would have read in the news, that a good majority of people who contracted the virus and passed away were people who were living in the residential homes, who were older people, or people who have comorbidities like diabetes, heart problems, or people who have underlying diseases where they are on immunosuppressive drugs like hematological conditions or cancers, or other transplant conditions like renal transplants. I just got this from the WHO dashboard. The disease keeps increasing, particularly in the Americas. North America, USA, and Brazil have been affected very badly. So what is this coronavirus? Corona comes from crown. It looks like a crown which the princesses wear on their head. It looks like that, and sun surface is called corona. It's like a circular shape. You can see it at the right-hand corner of your screen. The other term which was coined by the WHO was COVID-19, which means that CO is coronavirus, VI is a virus, and D, it causes the disease. Coronavirus disease. 19 means that it was first described in 2019. The official term, the virological term, is the SARS-CoV-2, which means the severe acute respiratory syndrome. This virus mostly causes the lung problems, but as we will talk later, that it is actually a systemic virus. But most people gets affected by their lung disease. It's SARS-CoV-2 because there was SARS-CoV-1. We'll come to that in a second. This is the history. These viruses were first described in chicken in the 1930s, and later in 1965 by Terrell and by now, they actually grew the virus in 1965 from the tracheal aspirates and were able to look at it under the electron microscope. Then there was a major outbreak in 1997 by common seasonal flu, which was called bird flu. And you would recall that the chicken went two chicken a pence. And the major outbreak was again in Hong Kong and China. In 2002 and 2003, there was a major outbreak of SARS-CoV-1. This was the first SARS virus, which started in Guangdong province in China. It affected about 29 countries, and there were about 774 deaths. Now, compared to this current SARS-CoV-2, this seems nothing. This was contained very nicely, and I'll come to the differences why SARS-CoV-2 is different from SARS-CoV-1. The mortality was quite higher than SARS-CoV-1. So if somebody acquired SARS-CoV-1, he or she would end up in the hospital requiring ventilation. In 2009, there was another seasonal flu, H1N1, which was called swine flu. And then in 2012, another virus came up when I was visiting Mecca at that time. There was an outbreak. It was called Middle Eastern respiratory virus. And again, this was coronavirus. And it again had very high mortality. It was said that it spread from the camels. The first case was erupted in Saudi Arabia, and many Middle Eastern countries were affected. There are occasional cases still occurring in that part of the world. Then comes this in 2019 SARS-CoV-2, which started in Wuhan. I never knew about this Wuhan before, only came to know recently after this outbreak came. Average mortality, which different studies are suggesting, is between 1.2 to 2%. Seasonal flu mortality is 1% or even less. So this virus has got a higher mortality as compared to the seasonal flu. Where this came from? Since there was a market for these wild animals and Oriental people love eating these animals, it was suggested that this came from the bats, but there is really no scientific evidence. Then the other people are suggesting that this came possibly from this pangolin, but again, we really don't know. There's a bat virus which has got a quite similar structure to the human type virus. This is a Chinese doctor, Dr. Li Wenliang, who actually was a whistleblower. He was an ophthalmologist. He was only 34 years old. And he started telling end of November to his colleagues that there is very, very severe pneumonia going on, which is very unusual, never seen before in Wuhan. And he was silenced by the Chinese authorities. He unfortunately contracted the virus and died. And as I mentioned, he was only 34. WHO declared the pandemic of COVID-19 on 11th of March, 2020. China declared the epidemic in December. It took 3 months for the WHO to tell us that there is this virus. Why was this late? I'll come to that in a second. This virus spreads massively in mass gatherings. There were a few clusters, like one in church in South Korea, the ski resorts in Italy and Australia, and the main was pilgrimage in Mashhad in Iran. A number of pilgrims who were when returning to Pakistan, they brought the virus to the Pakistan. And there's this cruise ship in Japan, and almost everybody got the virus. So far what we know is that virus is airborne. I'll come to that in a second. And if there are large gatherings, it spreads like a fire. It spreads via person to person, via breathing or via direct contact. If somebody touches the virus affected area, like surface, foamite glass or medical instruments, and then touches the eyes or face, contracts the virus. This virus is shed in the feces, but there is no scientific evidence that it is spread via fecal oral route so far. The first case of vertical transmission, mother to fetus, has just been reported in Nature from French author. Luckily, this baby is doing very well. Now, WHO has been reeling all the way. That's why Trump is so annoyed with the WHO and got out of it. They never said that it is airborne. Finally, these 230 scientists reported in an open letter that it is airborne and people should be advised to wear the mask. I'll come to the mask in a second. SARS-2 is less deadly as compared to SARS-1 and MERS. Why it spread so rapidly and became a pandemic as when we compare to SARS-2 and MERS? The reason being that many people are asymptomatic and the incubation period is, as compared to SARS-1 and MERS, is longer. So this person infectious, shedding the virus and still has no symptoms. That's why we recommend that people, even if they are asymptomatic, they should wear the virus to protect themselves as well as other fellows. This virus has 82% similarity to SARS-1 and 96% to the bat virus. That's why the people suggest that it came from the bats. And that's where the WHO went wrong. WHO felt that since SARS-1 and MERS were contained easily, this virus would have been contained easily. And that's why they took time to declare it as a pandemic. And even they were reeling for suggesting that it's airborne and people should wear masks. In terms of symptoms, it is a systemic disease, but mostly it affects the lungs. So it starts with upper respiratory tract infection, with sore throat, rhinorrhea, sneezing, headaches, body aches, and cough, particularly dry cough. And then it can affect the other organs less commonly. I'll come to that in a second. Sometimes it causes a diarrhea in few people. So most people, as I said, 70–90% are asymptomatic or with very mild symptoms of just fever and sore throat, and that's it, and then they recover. Particularly the children. The older people get more problems, or people with comorbids. Headache is a commonest symptom. Similarly, loss of smell was seen, and nasal obstruction, cough, and muscle aches and rhinorrhea. Loss of taste, sore throat, fever, dyspnea, and then the chills and nausea and diarrhea. Some people even presented with the acute coronary insufficiency. Virus tends to affect the myocytes. The RNA has been seen found in the myocytes as well. It causes arrhythmias and myocarditis and even cardiac failure. Sometimes people even present with CNS symptoms. It's sometimes present with encephalitis, and even it has been grown from the CSF. It affects the nerves, olfactory nerves, and it can cause meningitis or even Guillain-Barré syndrome, and sometimes it presents with a stroke. Sometimes it has got neuropsychiatric symptoms like altered mental state or seizures or even psychosis or dementia-like symptoms. As I said, it can cause diarrhea in up to 8% of people in some reported literature from Singapore, and but it's usually self-limiting and not very severe. Some people do get nausea, vomiting, and many are anorexic. And abnormal LFTs have been seen in a number of people. This ACE2 receptor and TMPRSS2 receptor are very well expressed. I'll come to that in a minute in GI, as well as biliary tract. So far, there is no scientific evidence that it is spread by the fecal-oral route. Some people do get eye symptoms, few percentage. They get conjunctivitis, itchy eyes, and epiphora. and it has been grown from conjunctival secretions. That's why the scientists suggest that we should not touch face and eyes. It also causes autoimmune kind of situations. There are cases report of ITP, and these have been successfully treated with actually steroids and IVIG, similarly Guillain-Barré syndrome, a few cases, and a milder Guillain-Barré syndrome like Miller-Fisher syndrome. There was a study from North America which showed a number of people had actually these antiphospholipid antibodies, but whether how much they were contributing to thrombosis, we don't know. I'll come to that thrombosis in a second. Then there is this Kawasaki-like syndrome, which is mainly seen in children, but in young adults as well. I'll come to that in a second. And people who have autoimmune diseases and are immunosuppressed, they are at high risk of the virus, and these people should be protected. Children do get this Kawasaki-like syndrome, which is more severe than the conventional Kawasaki, and about 5% get this very severe disease. They have rash, they have adenopathy, fever, mucositis, and swelling over the feet, and they get hyponatremia and metabolic acidosis. And these children should be admitted in the hospital and treated vigorously. Sometimes there's renal involvement, but not a lot, but mostly it is secondary due to either sepsis or shock. And many people go into ARF when the GIC sets in. People who have pre-existing renal disease, like people who are in immunosuppression, these are the people who should be protected. We lost one of the colleague, our class fellow. Unfortunately, he had a renal transplant and was in immunosuppression, and he died of the COVID virus. So how it works really, the virology itself, is an RNA virus, a single strand virus. By itself is useless. It doesn't cause any problem unless it finds a host. It enters the host via this ACE2 receptor, and this TMPRSS2 receptor helps it to get entry into the cell, mainly in the respiratory epithelium, like type 2 pneumocytes. And it is entered by receptor-mediated endocytosis, where the RNA is released, and then it infects the pneumocytes, where it proliferates, and then the whole problem starts. Since this causes the inflammation, there are lots of these cytokines, and these cause the cytokine storm, just like similar to the one we hear in people with autoimmune conditions. So mostly it is IL-1, IL-6, TNF alpha, and other factors. And these and other cells, inflammatory cells, walk in like B cells, T cells, neutrophils, and it's kind of self-propagating cycle. And they cause the capillaries permeability, and the endothelial cells, it's called endothelialitis. So there's the capillary leak syndrome, and the pneumocytes, these alveolar spaces get filled with fluid, and the patient starts feeling dyspneic and ends up on the ventilator. I'll tell you what the difference between the conventional ARDS and the ARDS in SARS, how different it is in a second. If it continues, it causes thickening of the interstitium, and I was talking to a friend of mine who is a chief of pathology in Nottingham University. He is a lung pathologist, and he has done a number of postmortem. He tells that a good number of people had lung disease, and their lungs are really completely ruined. And also, there was a lot of these endothelialitis, as well as lots of these microthrombi in a variety of vessels, both arterial and venous. This actually activates the clotting system, as you can see here, the kinin-Kallikrein system, which causes vascular permeability, as well as activation of the coagulation system, which causes the DIC and microthrombi. So people who overcome the condition, they have a healthy immune system. The CD8 cells destroy the virus-infected cells, and the antibodies are neutralizing. They overcome it. people who are unable, it kind of perpetuates the system, and more these cytokines are released, and they cause more these capillary permeability and causes the organ damage. And many of these people actually go on to acquire secondary pneumonias, and you will succumb to lung infections. This is at the postmortem. If you look at the massive alveolar damage, look at the hardly any alveolar, they are filled with all these inflammatory infiltrates, and also microthrombi. If you look at here, imaging is very good. A person who has been positive for COVID should have an X-ray. Conventional X-ray is not very sensitive. If you suspect there is COVID and there's a lung problem, we should do the CT scan. I was talking to a colleague of mine who is a neurologist in Pakistan. He did a very good webinar on CNS problems. He says that people who were presenting with CNS problem, they were actually doing their chest CTs just to make sure that it's not COVID. And if you look at here, there's, as I said, there's pulmonary vascular endotheliitis, which really invites, which fulfills the varicose triad and causes thrombosis. And there are actually new vessel formations. And this is really widespread. This is not only in the lungs. This is in every organ, in the heart, in the kidneys, in the liver, and you name it. So there is a multi-organ problem which leads to multi-organ failure. At the postmortem, the lungs really look horrible. You would have seen a report of a young girl who had lung failure, and she went on to have a successful lung transplant. So look at the lungs; they are really contracted. They are shrunken, and there are these massive infarcts. Briefly, hematology. Thrombocytopenia is common. So people who get thrombocytopenia, we get really activated, and we always make sure that this is not COVID. Lymphocytopenia is also seen in a number of people. One of the, excuse me, one of the prognostic marker is neutrophil to lymphocyte ratio. If it really gives a significant prognosis, if it's high, and many people are anemic. The D-dimer and fibrin D-dimer products go high. Some people go on to have a bleeding. You would have heard a case of the vice chancellor of Nisa University. Unfortunately, he developed a very serious bleed, and my colleagues were running up and down to get defectors Nova 7 for him. He unfortunately passed away. Similarly, as I said, the clotting factor system is activated. Prolonged PT is common, and thrombosis everywhere. Usually, we would recommend in people who get COVID that they should get aspirin at least, because there is both arterial and venous thrombosis. And also, if they are lying in the bed, they should be given pharmacological prophylaxis in the form of low-molecular heparin. What we are doing with the hematology patients here, most of our patients, we are shielding them at home, and minimal hospital visits. We are doing telephonic consultations and trying not to expose them to the hospital environment, which is a high-risk situation. And in many situations, we have done the abbreviated chemotherapy, particularly with the new AMLs. We are using venetoclax with low-dose RRC or azacitidine. I'm nearly there, Maureen. And we have been omitting Zomita in myeloma and rituximab in maintenance NHLs. So in conclusions, yes, there's a new virus. It's a flu virus, but we have to take it really seriously. It's unpredictable. We have to protect ourselves as well as our fellow colleagues and other people. We should wear masks whenever we are going out. Even one of my colleagues, who's professor of medicine at Liaquat, he says that we should wear a mask even at home. There's no vaccine yet, but I've just heard the news that the Oxford vaccine is really coming up. Even the Russians want this technology. They have been bugging into the system. It gives a very good antibody, but the problem is that the historical antibody levels fall away within a few months. We have to see how this vaccine comes up. It's airborne. Should we wear masks? It causes serious complications in people who survive. And many people have lung disease. Hematological effects are widespread. Most common is thrombosis, thrombocytopenia, and anemias. Many people need psychological support. Our CNs are day and night talking to our patients because our patients are really lodged in homes, unfortunately. So I leave it to Dr. Hashmi to dwell more on the hematological aspects. And I thank you very much. And if you have any questions.
Thank you very much, sir, for such a comprehensive lecture, so illustrated. I hope everybody would have enjoyed a lot. Question and answers are in chat, so you can answer them. It was very educative talk indeed. So we come to our next panelist. The next speaker is my worthy teacher, very honorable Professor Khalid Zafar Hashmi, Head of Hematology Department from Sindh Institute of Urology and Transplant. And sir has volunteered to speak upon hematological findings in COVID-19 patients, which we as hematologists come across every day. So for the next few months or so, these questions would be very frequent, which Dr. Hashmi would be explaining. Thank you very much, sir, for sparing your precious time. And over to Professor Khalid Zafar Hashmi. Thank you, sir.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. And thank you, PSH, for inviting us to participate in this webinar. Thank you, GN, for setting the stage for us. My presentation is in two parts. I'm going to do a little literature search and review. And then my colleague, Dr. Javeria Fahad Qureshi, she is going to present the SIUT experience. So far, we have seen more than 500 patients at SIUT and treated them. And we have their data, which is still under process. So that data is not yet ready for presentation, but she's going to share some of the lab data that we have in our possession here. There's no conflict of interest to disclose here, but I would like to thank two people. The person who has done all the typing of the manuscript, Mr. Uwais Raza, and then my daughter, Dr. Saman Hashmi. She is a pediatric hemato-oncologist at St. Jude's in Memphis, and she formatted the presentation for me. So thank you for that, Saman. Brief introduction. Gian has already told us about it. The disease, severe acute respiratory syndrome, coronavirus, SARS-CoV-2 as it's called, is a disease which started in December in the Chinese city of Wuhan. And it's now spread to more than 13 million people around the world. It primarily manifested as a respiratory tract infection, but with the available data, it should now be regarded as a systemic disease involving the cardiovascular, gastrointestinal, neurological, hemopoietic, and immune system, in addition to the respiratory system. When we look at the literature, most of the literature has originated from the various studies in the hospitals in China. And I've just shown a few of the examples of the literature that we searched. And most of the work has been in China, even if it's been reported outside China in Annals of Hematology or the American Journal of Hematology. But this is, I think, still a preliminary process. It will take some time before we really get to know the actual depth of the pathophysiology and other complications. So things keep on changing. Since we started making the presentation until the time that we have come to give this presentation, so many papers have been added, and certain other facts may have been added to it. Some may have been sort of changed a bit as well, but this is as it stands right now. The common laboratory investigations that were being done in hospitals that were based in areas where there were patients with COVID-19, and in our hospital as well, we were doing complete blood counts, the PT, APTT, and D-dimer, LDH and CRP as the inflammatory marker, and then the biomarkers ferritin and procalcitonin. Now, a study from the Singapore Center for Infectious Diseases, this was reported on 69 patients that they saw, and only 9 of the 69 patients required admission. Most of these patients had a normal blood count, and they did not report moderate or severe thrombocytopenia, as is normally seen with other viral infections. The peripheral blood count tends to stay in the normal range during the incubation period. One investigation which has been reported in most of the study is the lymphocyte count. Lymphocytopenia has been a constant feature in all of these studies that have been reported. The study from Singapore I was talking about, it showed that 20% of all patients had an absolute lymphocyte count of less than 1. Then reports coming from hospitals within Wuhan had a lymphopenia in 60% of the cases, while outside Wuhan it was in 42% of the cases. Interestingly enough, in the SARS-CoV epidemic, which was in 2003, the data which was analyzed from patients in Hong Kong and Singapore had also reported lymphopenia. Now, this point has recently been challenged by a report which has come out from the Netherlands. The study from Athens, Greece, and reported by Telpos et al., they reported that 69% of the patients had lymphocytopenia, and then some of these patients had reactive lymphocytes, including the plasmacytoid subset, something that we haven't really experienced. The flow cytometry did not reveal any inversion of the CD4-CD8 lymphocyte ratio. However, the impaired function of CD4 helper and regulatory T cell has been proposed because of the initial hyperactivation followed by rapid exhaustion of the cytotoxic CD8 T cells. In one patient whose blood was analyzed after death, they showed on flow cytometry that both the CD4 and the CD8 lymphocyte count had been reduced. Jean mentioned about cytokine storm. What is cytokine storm? Basically, 7 to 14 days after the clinical manifestation, there is a sudden surge in the clinical findings. And this is because of the pronounced systemic increase of the inflammatory mediators and cytokines. And at this point, lymphopenia is more pronounced. And some of these people have used lymphopenia to clinically correlate with the cytokine storm. A study reported by Huang and then by Wang et al. Highlighted the association between lymphopenia and the need for the ICU care. They also showed a fair amount of association between lymphopenia and then patients going into having ARDS. The SARS-CoV-2 infection basically results in the reduction of the ACE2 and increased expression of the ACE in the myeloid precursors, which facilitate myeloid maturation and made macrophages more pro-inflammatory. And there was a suppression of the myeloid-derived suppressor cells and activated T cells, which worsens the immune response of target cells and consumption of T cells. The pro-inflammatory macrophages cause severe immune damage to the lungs and other tissues. Continuing with the lymphocytopenia and the association with clinical features, the Singapore group found on admission the absolute lymphocyte count stood out as a discriminatory laboratory test. ICU patients had profound lymphocytopenia. The median NIDA was reported as 0.4. Then the studies reported by Wu et al. Showed an association between lymphocytopenia and the acute respiratory distress. The report which came out from Washington, and it was reported by Arends, they showed that the non-survivors demonstrated a more significant deterioration in lymphocytes compared to those who survived. And patients having myocardial injury had higher leukocyte count but lower lymphocyte and lower platelet count as well. What could be the cause of lymphocytopenia? The report from TREPOS suggested that there could be several factors which would contribute to the COVID-associated lymphocytopenia. One, the lymphocytes express the ACE2 receptors on their surface, thus the SARS-CoV-2 virus may directly infect these cells and cause lysis of these cells. Secondly, we just saw that the cytokine storm results in marked increase in the levels of interleukins and these enzymes, and this may promote lymphocyte apoptosis. Cytokine activation may be associated with the atrophy of the lymphoid organs and impair the lymphocyte turnover. And then the coexisting lactic acid acidosis may also inhibit lymphocyte proliferation. So much so about the lymphocyte. The next cell that was looked at were the neutrophils. There was this series that was reported which showed that the patients who went to ICU had a higher neutrophil count as compared to the patients who did not go to the ICU. The Singapore study suggested that the patients developed higher neutrophil counts during their stay in the hospital. They showed that the peak in the ICU patient was 11.6 as compared to the peak with the non-ICU patient where it was 3.5. They also showed that patients with ARDS had a higher neutrophil count as well as higher death rates. So most of the case reports are from hospitals in Wuhan, and patients in ICU have a higher neutrophil count, and this is an indicator of disease progression and higher mortality. The other investigation, which was initially probably used much more than now, is the so-called NLR ratio, the neutrophil lymphocyte ratio. In a data analysis, neutrophil to lymphocyte ratio was a useful predictor of the critical illness. They used a cutoff value of 3.13. NLR of less than 3.13 was regarded as low risk, and an NLR of more than 3.13 was regarded as a high risk. In many studies, NLR was reported as a better predictor of critical condition compared to the other scoring models that were used. Once again, the high troponin T levels have been reported to be associated with leukocytosis and neutrophilia. How about the platelets? There was a large series of more than 1,000 cases that was reported in which a platelet count of less than 150 into 10 to the power of 9 per liter was reported in 36% of the cases. So a third of these patients had a platelet count which was less than 150. And again, the cases that are severe, which was 57%, had increased susceptibility to thrombocytopenia as compared with the non-severe cases, which were 31.6%. What could be the mechanism? And this again is a postulation. Reduced platelet production by the coronavirus infecting bone marrow cells, resulting in abnormal hematopoiesis. The increased platelet destruction by autoantibodies and immune complexes, and the increased platelet consumption. Damaged lung tissue and pulmonary endothelial cells may activate platelets in the lung, resulting in aggregation and formation of microthrombi. And I'll come back to this point in a minute. Anemia has not been a common lab finding. However, some studies that came from the Jinyan Tan Hospital in China, they showed that the hemoglobin was below normal range in more than half of the 99 patients that they saw. And once again, the hemoglobin was lower in patients with severe disease. And this was a similar observation with our patients here. And the inflammatory changes could interfere with the hemoglobin synthesis, right? Okay, the coagulation abnormalities. The most common pattern of coagulopathy observed in COVID-19 hospitalized patient is the elevation of fibrinogen and D-dimer, which goes in parallel with the rise in the CRP. The PT and APTT are minimally prolonged, and we also saw the same thing here. We'll show you the data. Some lupus-like inhibitors have been reported in these cases. D-dimers of more than 0.5 milligram per liter were seen in half of the patients on admission in this report by Ghulam in the New England Journal of Medicine. Once again, the elevation was more pronounced in the ICU patients. D-dimer dynamics reflects the severity of the disease and its increasing levels are associated with an adverse outcome. D-dimer elevation and DIC may be common in patients with severe COVID-19 infection, and then the venous thromboembolism because of so many other reasons. Now, something which Gian mentioned was the endotheliopathy. Very recently, we have had a study which was reported by George Goshua on the inline study reported in Lancet about the possible role of endothelial cell injury in COVID-19 associated coagulopathy. And this is probably the first study coming out from the Yale School of Medicine, in which they have assayed biochemical markers to characterize what they are trying to say. They believe that the increase in the level of 1 Willebrand factor antigen, the soluble thrombomodulin, soluble P-lactin, soluble CD40 ligand, as well as coagulation factors, endogenous anticoagulants, and fibrinolysis, which they had measured actually, and measured with controls, was the key for all these things that was happening. The endothelial cells have ACE2 receptors on their surface, and they may be directly infected and injured by the virus, thus resulting in platelet activation and hypercoagulability. They concluded that the COVID-19 associated coagulopathy is an endotheliopathy that results in augmented 1 Willebrand factor release, platelet activation, and hypercoagulability, leading to clinical prothrombotic state, which can include venous arterial and microvascular thrombosis. This is a little different from the conventional DIC. In DIC, there is unmitigated activation of the coagulation cascade, and this results in the consumption of coagulation factors. However, here, the basic problem starts with endotheliopathy. Now, they point out that there may be a role for antiplatelet agents in addition to the traditional anticoagulant therapy. Then we know of the emerging role of biomarkers. People are looking at serum ferritin association with ARDS, non-survivors having a higher LDH, and C-reactive protein elevated in many of these patients. Procalcitonin elevation is suggestive of a secondary infection. So in conclusion, COVID-19 disease has a prominent manifestation in the hematopoietic system. Lymphocytopenia and NLR ratio can be predictive of adverse outcome. Evaluation of the baseline indices and follow-up during course of the disease can assist the clinician in providing intensive care, and preventive measures for thromboprophylaxis and early identification of potentially lethal complications like DIC may improve patient outcome and probably reduce the overall death rate. Now I'll hand over the mic to my colleague, Dr. Javeria, and she's going to share the SIUT experience with you here.
Assalamu alaikum. I'll start my presentation. I'll define the criteria for admission. We divided the patient into two. Those who were admitted in isolation ward and the other in the ICUs. In isolation, we were admitting all the COVID-19 positive patients who presented with tachypnea and had a respiratory rate of greater than 25 breaths per minute, and those who have oxygen saturation of less than 92% at room air, and those who were in a slightly confused state, and those patients who were greater than 55 years with comorbidities like diabetes, hypertension, end-stage renal disease, and ischemic heart disease. And once they were shifted in isolation, they were shifted to ICU when they were not able to maintain the oxygen saturation of greater than 88% despite of supplemental oxygen, or their respiratory rate was greater than 30 breaths per minute despite of all the available treatment. We have compared our data with a paper published in AGH. This is the data from Singapore. They took 58 patients, those who were in non-ICU, and they had 31 males and 27 females. While we recruited 50 patients in a non-ICU setting, and 34 among them were males and 16 were females. So their ratio from male to female was 2:1 and R was 1:1. And they looked at the CBC parameters. They looked at hemoglobin, and their median hemoglobin was 14.2, while R was 12.3. Our median hemoglobin was slightly lower than there because we had a lot of patients who had end-stage renal disease, and those patients had very low hemoglobin. Our lower hemoglobin recorded was 6.3. So our median was lower than them. Their WBC's count were 4.7, where our patient had a median WBC of 7.3. And when we look at ANC, their ANC was 2.9 lower than ours. Our patient had a median ANC of 5.2. And when we see the absolute lymphocyte count, their median absolute lymphocyte count was 1.3. Our absolute lymphocyte count was 1.0. The platelets were more or less same, that were 200,000, more than 200,000. And they didn't look at the other parameters, but we checked the D-dimers and coagulation parameters. PT, APTT of most of the patients was within normal limits. The D-dimers were slightly ranged. The median were 2.3 nanograms. Then they took the ICU patients. They presented 9 patients in that paper. Among them, 6 were males and 3 were female. The median hemoglobin of those patients was more or less same like that of non-ICU patient. It was 13.2 grams. The WBCs went higher. They were 5.1. The platelet were more or less same to the non-ICU patients. And when we look upon the ANC, it has raised. Their ANC now become 5.2 as we compare to the non-ICU setting, and the ALC goes down. It was 1, and when they were in ICU, they had a lower ALC, that is 0.5. Now, this is the blood profile of patient at SIUT, those who are in ICU. So we divided our data in 2 parts. We saw the parameters on admission at ICU and the other when they were discharged from the ICU. We saw an increase in hemoglobin concentration when these patients were shifted from ICU on recovery. On admission, they had the hemoglobin of 9.6, and when they were discharged, their hemoglobin rose to 12.25. So there was significant improvement in hemoglobin concentration on their recovery. The WBCs were more or less same, and the platelet were also the same between the ICU and the non-ICU setting. But there was difference between the ANC. The ANC was higher when they were shifted to ICU. But on the recovery, whether they were going home or they were shifted to isolation again, their ANC was decreasing. And when we go look at absolute lymphocyte count, they had lymphocytopenia, lower ALC when they were in ICU. On recovery, the ALC also improved. So there was significant improvement in hemoglobin concentration and the ALC. The PTA and APTT were more or less normal. And the if you look at the NLR, there was significant decrease in the neutrophil lymphocyte ratio when the patient were discharged from ICU. This is the graphical representation of our patients with the age. Our patient had a lower hemoglobin setting, lower hemoglobin if we see at non-ICU and ICU. Our patient had a lower hemoglobin as compared to them. Our patient had a higher WBC count as compared to the patient those at. This is the ANC. This is the absolute lymphocyte count. Platelet were more or less same. Again, the hemoglobin, WBCs. The absolute lymphocyte count of our patient was slightly higher as we compared to them. Their patient had a lower ALC because their total TLC was also low. The platelet were more or less same. And I would
Excuse me, Dr. Javeria. Sorry to interrupt. There is a suggestion to increase your volume. The participant wants you to speak a bit louder.
Volume, okay.
Sorry for interrupting.
No. We are going to end.
Is it any better now?
Kindly continue. बस आपकी आवाज का सब participants are suggesting कि थोड़ा सा ऊंचा बोल लें. A bit. Thank you.
I would like to conclude that our data showed that the hemoglobin concentration significantly improved when the patient were discharged from ICU or from the non-ICU setting, and there was an increase in the lymphocyte count on recovery. Actually, this was the data till 15th of May, and so far so now we have observed more than 500 samples, but we'll inshallah analyze that data soon.
We share some slides that we see.
These are the neutrophil. We are observing reactive neutrophilic lymphocytosis among patients with COVID-19. We are observing a lot of dysmorphic features among the neutrophils. Some are hypersegmentation is much more pronounced. This is the pseudo-Pelgarhi type of the cells. This is the lymphocytes. This is the hypersegmented neutrophil.
Thank you very much, Professor Khalid, Zafar, Hashmi, and Dr. Javeria, for such an educating talk. And thank you very much for including the local experience and morphology slides as well, because every talk is incomplete without morphology slides for hematologists. Thank you very much. And I think questions would be in the chat box. We'll be dealing with the questions afterwards. So thank you very much once again, Professor Khalid, Zafar, Hashmi, and Dr. Javeria. So now I would like to invite our third speaker, Dr. Samreen Sarfaraz. She's infectious disease specialist at Indus Hospital, Karachi. She's going to put us wiser about home and hospital management of COVID-19 patients. Over to Dr. Samreen Sarfaraz. Thank you very much, Dr. Samreen, for joining us.
Assalamu alaikum. So we are going to directly jump from lab and slides to direct patient care now, because I, as an infectious disease consultant at Indus Hospital, have been heading the COVID unit intensive care and COVID unit isolation in HDUs at the Indus Hospital, where we admit critical patients and serious patients mostly. So the game plan is that we are going to talk about phases of illness and how to grade severity, a bit of how to estimate the cytokine release storm, management of COVID patients, different varieties of COVID patients, and then isolation and de-isolation of these patients. If we look at this cycle, this is the natural history of COVID infection. In the first week, you have basically the viremic phase, where viral replication is happening big time. And as you enter the second week of illness, this is the pulmonary phase, where the host immune response starts to kick in, and the viral replication is also happening, but it is coming down a bit. And here you get to see differences in the responses that the patients exhibit. Some of them have mild respiratory tract illness, where their immune response overcomes the viral replication. Then you have certain people who get pneumonia. These are the ones who get moderate disease. Then you have those who have severe and critical disease with ARDS. And these are the patients where the host immune response is particularly very robust and persistent, and you get immune mediated damage. And then slowly you get a recovery or you get a death. So now I was talking about the immune response and the phases of illness. So about that, now we come on to how to grade severity of a patient. We have mild, moderate, severe, and critical. Mild disease we call when we have some symptoms which are consistent with COVID infection, but there are no chest infiltrates, and the oxygen saturation is more than 94% on room air, and there's no hemodynamic compromise. So all of these patients can be managed at home. 80% of patients fall in this category. Then we have moderate COVID disease, where you have chest infiltrates which are less than 50% of the chest, and you have mild hypoxia. This is oxygen saturation of between 90 to 94%. Then you go on to severe COVID disease, where you have a denser chest infiltrate of more than 50% of the chest, significant hypoxia with less than 90% on room air. The respiratory rate might be 30. Any of these can, if present, qualifies as severe disease, or you have severe respiratory distress observed in the patient. And then critical COVID is severe COVID with any of ARDS, septic shock, and multi-organ dysfunction. So this is from Pakistani guidelines and how we grade severity in our patients. We know that immunity is crucial to eliminate the invading virus, but paradoxically, a robust and persistent antiviral immune response leads to massive inflammatory cytokines, which we call the cytokine release syndrome or the cytokine storm. And this is when you see a host of cytokines released, IL-6, IL-2, IL-7, IL-10, TNF, GCSF, interferon gamma-induced protein. All of these cytokines, they are pro-inflammatory cytokines. Their levels have been reported to be high, and they cause inflammatory damage, and fibroblast activity is increased. There is edema in the lung tissue and many other tissues of the body. So there is a multi-organ manifestation which has been likened to secondary HLH. Mehta and colleagues first suggested that secondary hemophagocytic lymphohistiocytosis is associated with severe COVID-19 disease, and it is basically characterized by uncontrolled CRS and expansion of tissue macrophages and histiocytes with hemophagocytic activity. And activated alveolar macrophages expressing ACE2 are primary targets for the SARS-CoV-2 virus. And this is why we see an HLH-like CRS in COVID, which is characterized by hypercytokinemia, unremitting fevers, cytopenias, and hyperferritinemia. So based on this, the criteria in the Pakistani guidelines to assess for CRS is you can have any of the following: either a ferritin level of 1000 microgram per liter, which has and rising in last 24 hours, or if you have got an absolute value above 2000 in a patient with high oxygen demand, then this alone can is sufficient to label the patient as having CRS. Or you have lymphopenia less than 800 cells, or lymphocyte percentage of less than 20%, or a neutrophil lymphocyte ratio of above 5 with any two of these: CRP above 70, LDH 300, D-dimer 1000. I mean, or you have the, if you have the alternate reading, you have D-dimers reported as 1 or 0.5. So you can have those readings as well. And ferritin above 700 microgram per ml. Any of these two in conjunction with CBC abnormalities can be used to label a patient as having cytokine release syndrome. So now we come on to how do you manage these cases. The first thing is mild disease, which comprises about 80% of COVID patients. The most important thing in their management is that you have to isolate them so that they stop spreading the disease. So they can be isolated either at home if they have a provision of home isolation, or they need a dedicated isolation centers like they have been built at Expo or Gadap in Karachi and in Lahore and in different places as well. Institutional isolation if home isolation is not possible, and only symptomatic treatment is enough for them and they slowly recover. You have acetaminophen for fever, fluids, steam inhalation, and rest. And there is no role of steroids, antibiotics, aspirin, hydroxychloroquine, chloroquine, ivermectin, sanamaki. Social media disinformation I added on purpose because this is the most damaging thing which is happening. And people, when they just have a lab report, okay, they have COVID infection, and they start taking antibiotics, and they start taking this, that, and lasan and garlic and whatever and whatnot. You think of a concoction of stuff, and they are taking it, which is more harmful than the disease itself, right? So you have to basically limit yourself to just symptomatic home care, and patients usually recover. Then we come on to moderate COVID, where you see chest infiltrates, but these chest infiltrates are less than 50% of the chest. Now, ideally, they should be admitted in a well-ventilated ward, these patients, and because home management is a little risky, because moderate COVID patients can progress to severe and critical COVID. So one day they can be moderate, the other or 2 days later they can be severe. So they need monitoring. In selected cases, they can be managed at home, but there has to be a coordination with the treating doctor. Either the treating doctor gives them a home visit, or there is a good telecommunication between the doctor and the patient. The patient is well educated, then these patients can be managed at home. Or in many instances, we have doctors who have their relatives, and they can be treating their patients at home in those cases. Strict airborne and contact precautions need to be practiced, as we all know that now it's turning that this disease is airborne. So you need to wear masks and practice contact precautions, meaning gloves and gown, when you care for these patients, and they should be admitted in a well-ventilated area. You need to follow the markers to detect CRS, have a chest X-ray done, CBC, UC, CRP, ferritin, and repeat these labs only if there is an increasing oxygen demand. Procalcitonin should be done if the TLC is elevated, because we see TLC elevation quite frequently, but in the past 4 months, I have not detected much raise in procalcitonin. Less than 5% of patients have a raised procalcitonin. It means that the TLC is a reactive leukocytosis, and you do not need to prescribe antibiotics, because this is a viral infection. So just to basically curb down the instinct by the doctor to give antibiotic, do a procalcitonin if your TLC is raised, and if the procalcitonin is not raised, please do not prescribe antibiotics. And blood and sputum culture also should only be done if the TLC and procalcitonin is raised. Now, in moderate disease, you need to maintain the oxygen level above 94%, and alert proning helps in this. We know, we have seen that it is of much benefit. As long as the patient can remain prone, they should be prone. Remdesivir has a role here, and it really shortens the disease and prevents patients from going into CRS if it is given in moderate disease. And we have seen improvement in our patients. Obviously, this is just observational. This is just an observation from us. We don't have a randomized controlled trial to support this. But we start giving remdesivir if in moderate disease, if it is available. And along with that, standard thromboprophylaxis is very, very important in moderate disease, because these patients are bound to be on the bed because of hypoxia. So you need to start giving them heparin or enoxaparin if they are admitted in the hospital, or if they are managing at home, then rivaroxaban in select cases can also be given. If they are already on an anticoagulant, the same dose should be followed as before. As I said, do not prescribe antibiotics if the procalcitonin is not raised, and monitor for increasing oxygen requirement and development of CRS. This is of the utmost important, and for that you should have some objective scoring like μ2 score calculation, so that you know that the patient is progressing in his disease or remaining stable. Now, the role of steroids is becoming more and more pronounced. With the recovery trial, we have seen that steroids have made a difference in hypoxic patients when given at a dose of 6 milligrams per day for 10 days. These are from the recovery trial. And if you see that in patients where there was no oxygen demand, there was no mortality reduction. So steroids should not be used in patients who are not hypoxic, even if they have chest infiltrates. In patients who were on oxygen, there was a 20% mortality reduction, and in those who were on mechanical ventilation, there was a bigger difference in mortality, with the 28-day mortality decreasing to 35%. So the bottom line is that the steroids should only be used in those patients who have an oxygen requirement or are on invasive mechanical ventilation. And then there is a debate on the choice of steroid to use. For us in Pakistan, for the past 4 months, we have been very comfortable in using methylprednisolone and have had a very good result with it. But if you compare head-to-head dexamethasone with methylprednisolone, you see that the glucocorticoid activity of dexamethasone is much more as compared to methylprednisolone. When methylprednisolone has a more pronounced mineralocorticoid activity, dexa does not have any mineralocorticoid activity. So if you have a patient who is in shock, then probably methylprednisolone would be better than dexa. And for those who have profound inflammation, dexamethasone might be more useful, but there is no head-to-head comparison, and you might use either of them. And we have seen effects with good effects with methylprednisolone as well. So if you have a moderate disease with CRS, this is the type of patient who may progress. Today he's in moderate disease, he might be on 4 liters of oxygen, tomorrow he might be on 6 or 8 liters, and the third day he might be on 10 liters, and the fourth day he might be ventilated. So these are the patients you really need to follow very closely, and start giving steroids and follow the inflammatory markers. And if the inflammatory markers are showing rise or the oxygen requirement is increasing, it's preferable that you do an IL-6 level if it's available in your institution. And if the interleukin-6 levels are 3 times upper limit of normal, go ahead and give tocilizumab, because that has shown to stem the process of uncontrolled cytokine storm. Now we come on to severe and critical COVID disease. Now these patients need to be admitted in the ICU or HDU with strict airborne precautions, and you need to do certain baseline labs, then you need to do certain daily labs, and inflammatory markers need to be followed every 48 hours. And then there is a role of imaging as well in selected cases, like CT chest when you have suspicion of pulmonary thromboembolism, or when the oxygen requirement is persistently high or is not coming down, and you need to see what is happening in the chest. And then you might be needing neuroimaging in suspected cases of encephalitis and meningitis. You've seen several of encephalitis with COVID infection. You might also be needing ultrasound Doppler. We have seen limb gangrenes developing. We've seen radial arteries getting blocked. So these are selected investigations which need to be done in depending on the severity of the disease. Now, in severe and critical disease management, the mainstay of therapy is oxygen. For respiratory failure, frequently non-invasive ventilation like CPAP and BiPAP is used to avoid ventilation, and proning really helps in this. And you combine like high flow nasal cannula oxygen with proning, and the patient improves a lot in his oxygenation in real time. 12 to 16 hours of proning has been recommended, and in these patients, steroids have to be started, either dexamethasone or methylprednisolone, for a duration of 5 to 10 days. And then you monitor their SOFA scores and their PaO2 FiO2 ratio. Now I just listed this because this is very useful and for clinicians dealing with COVID, because you can have these charts estimate oxygen saturation with the PaO2 level, with the corresponding PaO2 level. Like at a saturation of 90, you have a PaO2 of 60. Similarly, if they estimate the amount of oxygen going from the nasal cannula or the nasopharyngeal catheter, whatever you're using, or the face mask, with the estimated FiO2 that you're providing, so that you can easily calculate the PaO2 FiO2 ratio, which is a very important measure, so that you know that your patient is going in ARDS, or if he is in ARDS, the ARDS is progressing or not. This is the SOFA score. You should calculate it on admission and then thereafter, because it has been shown to be associated with mortality. A SOFA score of 13 or more has a mortality of 95%. So as the score increases, the mortality increases. Now about IV tocilizumab, and tocilizumab should be used when you have CRS and the interleukin 6 levels are 3 times the upper limit of normal. It should not be given to ventilated patients who already have a higher chance of nosocomial infections, because it increases the risk of sepsis many times. And patients who are already immunocompromised, they should also not be given tocilizumab. And those who have severe comorbids like functional class 3 or 4 patients, or those who have severe heart failure, ESRD, etc. The contraindications to the use of tocilizumab are active TB or zoster, bacterial sepsis, or the suspicion of sepsis, and when your liver functions are deranged, or they're in multiple sclerosis, or when the ANC is less than 2000, or there's severe thrombocytopenia. In pregnancy as well, it's a category C drug, so it's a relative contraindication. You have to weigh the risk against the benefit. Remdesivir is emerging as the antiviral drug, which has shown some promise in decreasing viral shedding. And when you give, you have to start at a dose of 200 milligram IV on day 1, followed by 100 milligram IV daily for day 2 to 5. We are not using it for ventilated patients. We are seeing that it is not affecting them at all. And the data from international literature also shows that there is minimal effect on ventilated patients. It is most beneficial when it is used in the viremic phase, that is the first 10 days of illness, and it's basically a repurposed drug which inhibits viral RNA replication. The anticoagulation strategy has already been explained, because COVID has a significant coagulopathy associated with it. So this is from the American College of Haematology. This is what we are also following in our hospital, that we give a prophylaxis to everyone, standard prophylaxis, and we give therapeutic dose anticoagulation to those who have either confirmed thromboembolism, PE or DVT or whatever, or they have a presumed diagnosis, and on clinical grounds we are suspecting that they have it. But there is another thing which is called escalated dose prophylaxis, which means like a 40 milligram sub-QBD dose of enoxaparin. This is given to those patients who have a D-dimer raise of more than 3 times upper limit of normal, or they are in the ICU or on the vent, and have a high oxygen requirement. There we give this in accordance to Pakistani guidelines, which suggest that they have a higher chance of coagulopathy. International literature has also shown that despite standard prophylaxis, some patients with severe and critical COVID do go on and develop PE and other thromboembolic phenomena. So therefore, this thing about augmented prophylaxis has come in. Regarding other investigational therapies, convalescent plasma, ivermectin, lopinavir के लिए तो data is emerging that it is very ineffective. Favipiravir also is reserved for only very mild disease. All of these investigational therapies should be done in the context of a trial only and should not be used otherwise. Now we just come to the last 3 slides, symptom-based de-isolation. This is what we are doing in Pakistan now, because PCR positivity can remain for 3 months following an infection, and the patient has recovered, but you cannot afford to have such a long isolation period. So after 10 days from the start of symptoms and at least 3 days after symptom resolution, the patient can go ahead and stop his isolation and start carrying out his daily activities. In asymptomatic group, 10 days from the start of the test is enough. A test to document cure is no longer required in most cases. The only places where it is required is in immunocompromised patients, those living in congregations such as jails or dormitories or madrasas, and healthcare workers dealing with immunocompromised patients, for example, transplant recipients and active malignancy. So to summarize, first, you have to classify the patient into either moderate, severe, or critical COVID based on their oxygen saturations and their respiratory rates and their clinical condition. And then in the moderate disease, you do some baseline tests to determine if the patient is in CRS or not in CRS and requires oxygen or not. If the patient is not in CRS but requires oxygen, you give steroids and prophylactic anticoagulation, remdesivir, if it's available. And if the patient is in CRS, you also give tocilizumab if the condition is worsening. In critical and severe disease, you do baseline tests to determine the severity of the patient, if underlying cardiac involvement is there or not, and you do LFTs and procalcitonin if you're planning to give tocilizumab. The standard of care is to give steroids, tocilizumab if CRS is present and the interleukin-6 levels are raised, and remdesivir regardless of CRS. Augmented prophylaxis should be given in patients with severe and critical disease. Therapeutic only if you have confirmed or presumed VTE, or the D dimer is more than 3 times upper limit of normal. And antibiotics should only be given if the procalcitonin is high along with leukocytosis, or you have some other evidence of bacterial infection, for example, a positive culture, because antibiotics are not anti-TLC drugs. This is my main message as an ID professional, because I'm seeing a lot of antibiotic abuse with COVID-19, and COVID-19 is a viral infection and it's not a bacterial infection. So we should basically remember this. Thank you.
Thank you very much, Dr. Samreen. Obviously, the audience can email you about the further guidance or questions, and the audience is most welcome to email all the panelists if they allow for the answer to further questions. Most of the questions and question and answers tab. So the last panelist for this webinar is, last but not the least, is my very own teacher, a very senior transplant physician, heading Bone Marrow Transplant Center of Armed Forces, Brigadier Qamar Nisa Chaudhry. She's going to throw light upon management of hematological diseases and bone marrow transplant in COVID-19 era. So over to Madam Qamar.
Ladies and gentlemen, thank you so much to PSH for giving all of us this opportunity to meet and to share our knowledge and experiences. And as we've all seen from the excellent talks that we've had this morning, the coronavirus pandemic has posed unprecedented challenges to all of us, to all spheres of life, and patients with hematological disorders and the physicians caring for them are no exception. So I'll be talking particularly about hematological malignancies and transplant. So we just have 20 minutes. We'll just be touching on each malignancy in turn. So the very early data out of Wuhan showed that there was a high incidence of coronavirus infection in cancer patients. So about 2 to 3-fold higher in cancer patients. And later data has shown that the incidence for severe disease, and in fact ICU admissions, is about 50% higher in patients with hematological malignancies. A very large study out of the UK, an analysis of more than 10,000 deaths, has recently shown that patients with hematological malignancies are 4 times more likely to die as compared to the normal population and to patients who are suffering from other malignancies. Now, this higher risk, unfortunately, persists beyond even 5 years after they've had treatment for the blood cancer. So there are multiple reasons for this behavior. The disease itself, related cytopenias and immunodeficiency, the treatment-associated cytopenias and immunosuppression. Then the treatments are toxic. There are numerous drug interactions, and of course, the pandemic itself has imposed logistic concerns as well. So we'll begin with the general measures. These are for all hematology setups, but particularly for bone marrow transplant setups as well. The first would be to reduce outdoor visits, and this has been pointed out by Dr. Ghulam Nabi Kakepoto as well, and limiting hospital admissions to only when absolutely essential. So this would mean that we would have to have some sort of telemedicine so that patients can have their labs done locally and maybe send them to us through WhatsApp. It would also mean that we would need to replace many injectables with possibly oral treatments were available. Now, testing for the coronavirus is not available everywhere. However, it is recommended by the international by the infectious diseases, and they include chemotherapy, immunotherapy, cellular therapies, and high-dose steroids, as well as bone marrow transplant into immunosuppressive treatments. And in fact, they are very immunosuppressive and are used in a wide variety of hematological disorders in addition to malignancies. So patients, if they're admitted to the hospital, should be nursed in single rooms whenever possible, and standard protective measures which are required for these hematology patients should be put in place. But now we need also to put in place the use of appropriate PPE. Attendants, who are usually quite common in our setup, and people want to accompany patients to the hospital, have to be limited, and they should be only allowed in when they're absolutely required, and that too only one per patient. And our center, like many other hematology setups, is not allowing visitors to the indoor setup. So for any hematology or transplant setup, you would need to devise new SOPs, keeping in view the current scenario, and these SOPs have to be dynamic, and so that they can be adjusted according to emerging evidence and guidelines. We've had to train our staff who were already trained in hand washing and the use of PPE, but that has been augmented in the current scenario. And this training has been given to all staff at all tiers. So this includes physicians, nurses, helpers in the ward, cleaners, and all the auxiliary staff in the hospital. Surface cleaning is an essential part, with including disinfection and surface cleaning as an essential part of running any hematology unit, but that has to be stepped up, and appropriate disinfectants, including H2O2 vaporization and cleaning surfaces with dilute bleach solutions, has been put in place and would be needed. Now, contact tracing and taking staff off work when they've been exposed or when they develop symptoms, that's extremely important. And we've had to do that, and that has put a large amount of burden on the remaining staff who have to then continue the work and may have to have long hours on duty. We have encouraged our staff to self-report when they develop symptoms, or if any member of their family or their colleagues develop symptoms or test positive. And this may seem strange, but this has not been a major problem with us. People do report when they do face this kind of situation, and we've not had to send people off work when they're just trying to get off work. So for admissions to the hematology setup, patients and any attendants that they may need, or any donors that they may need, should have a negative PCR, and this should be within 48 hours prior to admission. It can be stretched to 72 hours, but we prefer to have a negative test within the last 48 hours. What we've done is that we have initial admission to a designated separate ward, and that the HVAC system with positive pressure has been turned off there. The patients are nursed there, and they're transferred to the main unit once they have a negative repeat test, and that should be at least 48 hours apart. And the patients should remain asymptomatic for COVID-19 symptoms. In terms of transplant, transplant is a very intensive procedure, and general recommendations internationally are to reduce elective transplantation to the bare essential and life-saving procedures only. So that's what we've done as well. So we're doing very severe aplastic anemia, very high-risk acute leukemias in CR1 or beyond, and patients with severe combined immunodeficiency, etc. These patients are required, as per the EBMT as well, to self-isolate at home for about 2 weeks prior to bone marrow transplant, and this is recommended both for the patients as well as the donors. And we are also asking the attendants to self-isolate at home. All should be asymptomatic for at least 14 days and preferably for 21 days with no positive contact history when they come to the hospital. And they should be tested for coronavirus before you start the mobilization of the donor and the conditioning regimen. It is preferable to collect and cryopreserve stem cells before you start conditioning. That way you don't need to worry too much about the donor. And PBSCs are preferable because it reduces the risks associated with the harvest where aerosolization of blood can occur. And likewise, it's easier to cryopreserve PBSCs, which wouldn't need any processing before freezing. And this way you don't need to worry about the donor. And in fact, it makes it a bit easier, but obviously this can be done only in centers where cryopreservation facilities are available and running. So coming to specific diseases, there are generally no specific recommendations by scientific societies. A recent recommendation has come from NCRI, the AML Working Party, and they recommend screening patients before you give any induction consolidation chemotherapy. If the patient tests positive, then therapy should generally be delayed if possible. Now, most patients would not be very symptomatic and are generally stable when they present to the hospital. But obviously there are patients who would need urgent treatment, and this would include patients who have very high white cell counts or other symptoms at presentation. For adults, young adults less than 60 years of age with favorable or even intermediate risk cytogenetics, these patients should be given standard induction with D3A7 or a similar regimen. However, if they go into remission, then consolidation can be reduced, and this would reduce cytarabine exposure. And you can give the intermediate dose at 1.5 gram per meter square to all patients. This would allow a quicker recovery of the blood counts. And we have seen in previous studies that there is no statistical effect on the overall survival between the high dose RSC and the intermediate dose. So if patients are MRD negative after the second cycle of treatment, then several experts are suggesting omitting the fourth cycle. So that would mean that you give one cycle of induction chemotherapy followed by two cycles of intermediate dose. And this would obviously mandate sequential MRD monitoring and preemptive intervention if there is a molecular relapse down the line. There are obviously less intensive therapy approaches that Dr. Kakepoto also mentioned in his talk, and there have been durable responses to venetoclax-based regimens. This has been seen particularly for patients who are NPM1 positive. Venetoclax can be paired with low-dose cytarabine or azacitidine or decitabine, and we have been using all of these regimens. This can be used for as a bridging strategy for patients who are more than 50 or the patients who have significant comorbidities, and very few selected older patients. Generally, if older patients tend to have non-proliferative disease, and they usually have lower counts and generally would present with transfusion requirements rather than marked cytopenias. In these patients, treatment should be deferred. Patients who are older and who have comorbidities and or disease characteristics which show that they're not likely to respond should be put on supportive care and can be given hydroxyurea if they have higher counts. So growth factor support would reduce the duration of neutropenia and obviously reduce the risk of febrile neutropenia, and are indicated in this situation for patients who have high platelet transfusion requirements or who are platelet refractory. Antifibrinolytics can be used and they may be beneficial, and similarly erythropoietin can be used to reduce red cell requirements. Ultimately, if you still need to give transfusions, generally one would want to lower the transfusion threshold if there are problems in transfusion to a hemoglobin of 7 grams and platelets to 10, but this would apply to patients who do not have symptoms of anemia and are not bleeding. So as I said, transplant in AML would generally, we would want to defer it. And in fact, for intermediate risk too, it's not being recommended at the moment. It can be carried out for fit adult patients who have high-risk disease and are in CR1. So this would mean patients who have not gone into complete remission after the first cycle of chemotherapy, or who have persistent MRD after the second cycle, or a re-emergence of MRD. It would also include patients who are in CR2 or beyond and have a suitable donor. And importantly, patients should be fit to tolerate and undergo the procedure. For acute promyelocytic leukemia, standard ATO/ATRA induction in low and intermediate risk disease and AIDA induction in high risk APML is recommended. We haven't done any APML during the COVID crisis. There is a recommendation to delay addition of ATOs to reduce the risk of the differentiation syndrome. So if patients are MRD negative after the second cycle, then we can consider omitting the last cycle of consolidation. And obviously these patients would require ongoing MRD monitoring and then adjustment of the treatment accordingly. So coming to CML, this is one of those disorders that a lot of us are seeing, and fortunately chronic phase CML and its treatment both are not associated with immune suppression. So newly diagnosed patients in chronic phase and patients who already are on TKIs are recommended to continue that treatment. There is no preference for any TKI, but some, like dasatinib, are associated with more pulmonary side effects, and we need to keep that in mind. We would need to monitor blood counts 1 to 2 weekly, with dose interruptions where required to prevent cytopenias, because we don't want patients to become neutropenic. It would be preferable to do a PCR for COVID-19 at the start of the TKI, so that you know that the patient is not infected, and if any pulmonary symptoms or the symptoms develop later on, it would be easier to decide what's happening. So during the COVID epidemic, one would not want to attempt a TFR, treatment-free remission, in a patient who is stable and PCR and BCR-ABL negative. Generally, the attempts of this sort should be put off until we are in better conditions. Patients who already are on a TFR and have been on one for less than 6 to 12 months, and if they have no access to regular monitoring, are at risk of relapses which may go undetected. So it is possible to restart a TKI and probably should be given consideration. Patients who have accelerated or blast phase disease can and should be attempted to be managed with a TKI alone. And however, for blast phase in a younger patient, one would need obviously combination chemotherapy in addition to a TKI. So patients with CML, if they were to become positive for COVID-19, generally you would not need to interrupt the TKI if they are not symptomatic, but if symptoms develop, then TKI should be withheld to decrease the lung stress during the infection and also the period of recovery. And obviously, as I already mentioned, we do need to remember that these drugs do have lung side effects. They also prolong the QT interval and can interact with drugs which are used for the treatment, like chloroquine and azithromycin. So other MPNs like polycythemia vera and ET, they are associated both with thrombotic and hemorrhagic complications, and we do know that thromboembolic complications are associated with severe and advanced COVID-19, although there is no data so far that shows an increased risk for these patients to have similar events if they were to develop COVID. So the recommendation from most experts is to strictly adhere to treatment goals, and to add cytoreduction where indicated, and we should try to achieve treatment goals set out by the ELN, that is a hematocrit of less than 45, lower leukocyte and platelet counts into the normal range. All patients who have polycythemia and ET should be given antiplatelet therapy. And we should remember that these patients are at a risk of increased bleeding if they are given anticoagulation, and especially if they have very high or very low platelet counts. Now, multiple myeloma is a disease which has actually been associated with the most morbidity and mortality in terms of COVID-19. In fact, we have lost 3 patients, 2 with multiple myeloma, which was controlled, and 1 with plasma cell leukemia during the current epidemic. So obviously there are multiple reasons. These patients are older, they have other comorbids, the disease has multiple immune effects, and the treatment itself has multiple immune effects. So the infection risk is much, much higher. So in a patient who is diagnosed with multiple myeloma, at initial presentation, one can defer the treatment, and generally the European myeloma, the EMA recommends deferring of treatment in patients except for those who need the treatment because of end organ damage or who present with myeloma-related emergencies or have aggressive relapses. Preferably oral agents should be given, and especially for older and frailer patients. Experts are suggesting intensifying treatments, reducing the doses of dexamethasone and proteasome inhibitors, as well as daratumumab. All of these have been associated with more severe COVID presentations if patients were to get the infection. And bone marrow transplant, wherever indicated, should be deferred. For patients who present with relapses, and if they are not very symptomatic and there are no other strong indications for treatment, watchful waiting is preferred. So coming to ALL, I think this is the area where we have the least number of recommendations. Testing, as for all other hematological malignancies, is required, and if the test for COVID-19 comes out positive, then delaying systemic treatment should be the way to go. But for patients who have CNS symptoms, intrathecal treatment should be initiated, even if COVID positive. So the ALL, as you know, is a very aggressive blood cancer, and these patients would require standard curative induction therapy. Steroids form a crucial part of this treatment, but there has been a large amount of controversy about their use. Despite the recent results of the recovery trial, in which low-dose steroids were found to be useful in coronavirus patients who were on ventilatory or oxygen support, there's not a lot of expert opinion favoring high-dose steroid use in ALL. And in fact, several experts recommend minimizing their use to perhaps just as antiemetic therapy. There's also expert opinion favoring reduction in the anthracycline dose and not giving very high dose bisglycinase, limiting it to 1,000 international units per meter square. G-CSF should be used to facilitate the white cell count after chemotherapy, and patients with Philadelphia positive ALL would benefit, of course, from TKIs, but perhaps they would need a modified induction chemotherapy. Rituximab is another drug where there's quite a bit of controversy, and many experts would recommend giving rituximab to patients who are younger and who have immunoglobulin levels within a fairly good range. So patients who have very low levels should not be given rituximab. Bone marrow transplant is indicated for patients in this particular setting with high-risk disease only. Patients who are already on maintenance or who are going to be put on maintenance, we should attempt to keep a higher absolute neutrophil count, around 1 or a little higher, to avoid superadded infections. And again, in maintenance therapy, many experts are reducing the dose of glucocorticoids and are avoiding vincristine altogether. So a pretty difficult scenario treating ALL patients with all these doubts and difficulties in delivery of adequate treatment. So lymphomas, again, high-grade lymphomas are a difficult situation. Aggressive standard chemotherapy should be given to aggressive lymphomas, and our attempt should be to bring these patients into remission as much as possible. It is obviously, again, in this situation, desirable to reduce the number of outpatient visits, and hopefully in many centers, they can be replaced with telemedicine and local labs wherever possible. autologous transplants should be deferred. These recommendations are consistent with guidance from EHA and the European Bone Marrow Transplant Association. For low-grade lymphomas like SLL, CLL, mantle cell or marginal zone lymphoma, etc., or follicular lymphoma, it is preferable to wait and watch. And generally, because many of these patients are much older and are not going to tolerate chemotherapy so well, so probably that should be deferred. Fortunately,
I'm sorry for interruption again. There is a request for a louder voice.
I'm so sorry. I'm sorry. I'm so sorry. I'm so sorry. So, okay, I hope I'm louder. I'm so sorry. Yeah. So I hope I'm more audible right now. So the approach to a low-grade, okay, so the approach to a low-grade lymphoma would be to wait and to watch and wait, and to only give treatment when it is needed. So fortunately, ibrutinib, the BTK inhibitor, has been seen to reduce macrophage activation, and that can be useful in can be helpful in reducing the risk of the CRS if these patients were to get severe COVID infection. And in fact, it's one of those drugs which is recommended to be continued in patients. So patients who have CLL, mantle cell lymphoma, or marginal zone lymphoma can be continued on ibrutinib. Unfortunately, it's an oral medication, so that results in another issue. For Hodgkin lymphoma, patients would require standard chemotherapy, and we should attempt to keep patients in the outpatient as much as possible. Again, here, autologously. So aplastic anemia, not a malignancy, but we do see so many of these patients, and in fact, they form a major chunk of the transplant population at our center. Now, in this setting, T-cell depleting treatments like ATG are not recommended in the COVID epidemic, and this is because we don't want these patients to have lymphopenia. Both B-cell lymphopenia and T-cell lymphopenia, both are not going to be good for the outcome of patients if they were to get COVID infection. So in the current setting, thrombopoietin receptor agonists are preferable, although the responses to these may be slower, but because these are oral medications and can be given in the outdoor setting and have very few side effects, so they're the preferable option. Patients can also be put on cyclosporin, and there would be issues with the monitoring of the cyclosporin level. In fact, patients who already have had a transplant and are on cyclosporin, or are on cyclosporin without having had a transplant, one shouldn't try to taper the cyclosporin during this epidemic, because you cannot monitor the count so frequently, and if they relapse, then you would have more problems. Transplant should be deferred for aplastic anemia like other indications, and however, being a very severe disease in many patients, so patients who have very severe disease would need a transplant, and then you would have to follow that rigorous protocol for taking them onto LYMPHOCYTOPENIA. Patient with a hematology disease were to get COVID, well, there is no universal guideline. The general recommendations are a minimum of 14 days from the onset of the symptoms, and a minimum of 72 hours after resolution of symptoms. So this is in line with the resumption of treatment and other activities after COVID by most experts. So this is what people are generally recommending for hematology as well. And patients should have 2 successive negative PCR tests, and these should be at least 24 hours apart. So we can see that the COVID-19 pandemic has taken us by surprise. It has increased the challenges in an already very challenging field. The evidence on the management of blood disorders is scanty, and we hope that more evidence will come up and it'll make our job easier. And hopefully we will we'll find it easier to manage patients and make day-to-day decisions. For today, most of our decisions have to be on case-to-case basis. They have to be on the availability of resources. as well as the COVID-19 prevalence in that particular part of the city or in the country, and its impact on the health services in that particular setup. So I've come to the end, and if there are any questions, obviously I'll be happy to answer those. I hope I was audible for most of the presentation.
Thank you very much for such an educating talk. It was, you made all of us wiser for the treatment of hematological diseases in COVID-19 era, and especially the transplanters. Thank you very much. The talk was very helpful for all the hematologists, hemo-oncologists, and transplanters. Most of the questions have been answered by most of them. There are 2-3 questions left. One, I think, for that should COVID-19 PCR be advised before bone marrow examination?
Okay, so I know that's a difficult question. And a lot of people have stopped doing bone marrow aspiration and refined biopsies. So the general recommendation is that for procedures that require more than 15 minutes of patient and doctor contact, you would possibly need a PCR. But I think most bone marrow procedures can be carried out in a shorter period of time, although history taking would take obviously much longer. And once we're using adequate protective gear and the patient is not symptomatic, the risk of transmission is quite low. So we at our center are continuing to do bone marrows without testing.
Thank you very much, madam.
We don't do the bone marrows. We don't do the testing before the bone marrows either, unless there is risk that the patient have been exposed to any known contact or something like that. It's not routine, but we have certainly decreased the number.
Thank you very much. We searched the International Committee of UK as well for this aerosol producing procedure. So they find it from Royal Smith Hospital, Hammersmith Hospital, as well as Royal Free Hospital, that this is not an aerosol generating procedure. So PCR for COVID-19 is not required for it. So with this, we come to the end of today's webinar, which was very successful at more than 150 participants registered and more than 85 were present till the end. So thank you very much, everybody. I express my deepest gratitude to Professor Khalid Zafar Hashmi, Dr. Samreen Sarfaraz, and and they were very helpful for all the hematologists and oncologists and trainees who were here and the practicing physician. Thank you very much. With this, I hand over the mic to President Dr. Pervez Ahmed for his final remarks, and we'll be seeing you in the next webinar afterwards. Thank you very much.
I want to convey my sincere thanks from myself and the PSH to all the worthy speakers for giving very educating and illuminating talk. And I think it was one of the most useful topic that was, need of the day to conduct a webinar on this particular topic. And thank you very much for the great interest to all the participants. And thank you all for sparing your weekend for this particular webinar. Thank you very much.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you so much.